you all set? Okay. Everybody all set up front? Okay. Well, good morning, ladies and gentlemen. My name is Carl Nathy with the University of Kentucky Public Relations and Marketing Office, and it is a sincere pleasure to have you joining us here this morning. We are celebrating yet another UK milestone. More than 3 million Americans suffer from epilepsy. Many of those people cannot control their seizures with medication. The Neuropace RNS system has given some patients with medication-resistant chronic epilepsy new hope. And last November, UK Healthcare became the first in Kentucky to implant the Neuropace RNS system. Dr. Craig Van Horn is a physician scientist who combines his clinical neurosurgical practice with his research investigating ways to restore function and repair damage to the central nervous system. Dr. Van Horn's interests focus on deep brain stimulation for movement disorders such as Parkinson's disease, and under his leadership, UK's Deep Brain Stimulation Program has achieved top 10 status for movement disorders. It is my privilege to give you Dr. Craig Van Horn, Associate Professor of Neurosurgery and co-founder of the Brain Restoration Center at the Kentucky Neuroscience Institute. Dr. Van Horn.
Great. Thank you for the introduction, and thank you to you all for coming out to participate in this. Thank you for Cheryl for coming out as well. I'd like to take the opportunity to tell you about this new device and this new therapy that we have for epilepsy. And although this may sound at times like an infomercial, I'd like to make sure that you know that I have no financial conflicts of interest in this device. That being said, this is truly an amazing feat of biomedical engineering. And what this device does is that it provides stimulation to the brain, but unlike what we see with other devices that do that, this device actually listens to the brain and monitors brain activity. And when it detects signals in the brain that are abnormal, those types of signals that lead to seizures, it then provides stimulation to those areas of the brain and prevents the seizure from happening or the seizure from spreading. And as I said, this is truly a feat of engineering to be able to do this. This has been in the works for over a decade. And what I'll do is I'll tell you a little bit about how it works and then what we've done to be able to get this so that we can treat Cheryl in her case. And one of the reasons that it's, or I say the indications for this kind of device are for patients who are not able to be treated with medications and who have a seizure in a location in the brain that makes it to take out that area of the brain surgically without causing a big deficit. So the trick, as in with Cheryl's case, is that you really need to find the area of the brain where the seizure activity is happening. So in Cheryl's case, we monitored, we surgically implanted a grid over parts of her brain, and we monitored that brain activity for over a week. And then when she had a seizure, we could pinpoint the exact location of the focus of that seizure. In another surgery, we then went back in and we implanted an electrode that's similar to this over that area of abnormal signaling in the brain. And then we implanted this device. This is the device that monitors the activity and then provides it to that area of the brain. We implanted this just beneath the scalp into the skull. And so that was the second surgery. And so Cheryl, how has that been so far?
I feel a whole lot better. My speech is incredibly a lot better. It was slurred. Mm-hmm. One type of seizure is about 50%.
Mm-hmm. Great.
And me and Dr. Benson was talking on the phone about our seizure, the seizures I have. Mm-hmm. And what would you know? Your opinion?
And you mentioned, Cheryl, that you had a reduction about 50%. That was your perception,
Yes.
and they're not as severe. Is that correct?
Yes. Yes. When I do have the seizures, they're not as severe as and intense. They're very more mild, and I just I'm very thankful for letting them help me be a candidate for this, because I wouldn't do nothing at the house. It was like I couldn't do nothing. It was so very intense, where I would have seizures, and I would
And you would have them every day.
yes,
Yes.
very daily. And I just got to the point where I sat on the couch and just watched TV, and I didn't get this. We used to do a lot of sports and everything with my boys, my husband, and it just wasn't the same anymore. I was just so depressed, and right now my speech is a lot better. I just can't get over that, and my seizures is just a lot more mild, and
The level of energy has increased. You mentioned too.
yes,
Is that right?
yes. When I take my medicine, I kind of conk out, but besides that, my husband and me drive around in the truck, and we get out more. It's very refreshing. I'm not used to it, and I'm still trying to build up to it, but I'm so thankful.
Miriam, you've worked with her quite a while, so why don't you
Yeah,
tell us
so-
about the...
Yeah, well, so I've known Cheryl for probably 8 years now. She's been my patient for the past 8 years. And Cheryl has struggled with seizures for almost 2 decades. And she has daily seizures, and several seizures a day, every single day. So this has confined her to her house. And but despite this, she was still able to raise 3 wonderful young gentlemen who are here in the audience. And so Cheryl is currently on 5 anti-seizure medications. So she takes these at the same time, all 5 of them. She also has a device, another neurostimulation device that's different than the one that was just implanted, the vagus nerve stimulator, that delivers stimulations periodically. So this device, the Neuropace, is much more clever because it is able to detect the and to deliver therapy when it recognizes the seizure pattern. So despite being on 5 seizure medications, having a vagus nerve stimulator implanted, and also she was considered for surgery 4 years ago. So Cheryl already underwent brain surgery 4 years ago. But at that time, we determined that the focus of her seizures, the source of her seizures could not be removed because it was near a function, near an area where there was brain function. That means if we had removed that area, she would have been paralyzed. And mainly it would have affected her face and tongue. She would have lost function there. So at that time, we could not resect the source of her seizures. And so for the past 4 years, she waited for a novel therapy. And we were very excited when the FDA approved the responsive neurostimulator from Neuropace a little bit over a year ago. And we're very excited to be able to offer this to our patients in Kentucky with difficult-to-control seizures like Cheryl.
Yes. The minute she brought that up to me and about the device, I jumped at it.
Yeah, she was ready. She was ready.
And she says, "You need any information about it?" I'm ready.
I think she was ready to have it that same day.
Yeah.
But it's a process. So and Cheryl
Yes.
knows that it's a process. We have to do what we call a pre-surgical workup. It's an extensive workup that several members of the team. So it's not a one-man show. We have, of course, the neurosurgeon, Dr. Greg Van Horn, but we have a neuropsychologist working with us, neuroradiologist. I have my other colleagues, epileptologist, and to keep us all together, we have a wonderful nurse coordinator, Rachel Ward Mitchell, who will make sure that we're all, doing what we should do and keeps us on time, on schedule. So it's a teamwork, and it's a process. So we have to collect the data, we have to do all these testing, and put all that information together. I'm sorry, I keep losing my voice.
If I might just interject
Sure.
for the media's benefit, you've been listening to Dr. Miriam Bensalem Owen, and she is director of the Comprehensive Epilepsy Program at the Kentucky Neuroscience Institute here at UK Healthcare. Now, I want to let you continue, and Dr. Van Horn, I didn't know if you had additional comments or you wanted to bring them up later.
We can bring them up later,
Okay.
I think.
Well, Dr. Bensalem Owen, you were making comments, and I think you have your voice back now. So.
Yes, I do. Very good. And I just think it's wonderful to have actually Cheryl. The last time I spoke with her on the phone, which was a few days ago, she told me that she was actually getting out of the house more often, which she wouldn't do before. It is for patients who have difficult to control seizures, having them in public is very embarrassing. But then there is a risk of injuries just by falls and from the seizures themselves. But Cheryl actually had a fall, and it was a fall that was not caused by a seizure for once.
No.
I think she slipped on the ice. This is what
Black
happened a few
ice.
days ago.
Well, if I might just introduce to Cheryl, so that to give the people out here a little bit of information about you. Cheryl Castle is from Lomansville, Kentucky. That's in Lawrence County. That's near Louisa. She has suffered from debilitating seizures for 18 years. And you've heard about her epilepsy and how UK Healthcare has helped her. Cheryl, I wanted you to introduce members of your family that are here with us that you've brought along today.
Okay. My mother, she's helped me a lot driving me down. And my boys, my three boys, Mitchell, Nathaniel, and Michael. And my husband was unable to make the
He had a
trip.
good reason, though.
Yes, he had good reason. He's in college. And he has for electrician, and he's picking up his tools, and it's just one of those college days you just can't miss. You don't get your equipment and everything. So, they really hung in there and took their times, and when I would have my grandmother's seizures, they would help me. There would, especially Mitchell, he's had it kind of rough.
He's the oldest.
Yeah. It got to the point where I wouldn't go to the hospitals up there, and they would basically just send me back home, and it seemed like they just didn't understand. They would just, so my mom or my husband would drive, and my son would be, and when I'd have a seizure, I'd be beat. So he had to go through that, and they've really hung with me.
They've been very supportive, yeah. They've been very
Yes,
supportive
very.
family, yeah. But you mentioned about the hospital, so can you tell us more what, when you go to the emergency room, what would happen?
I had one doctor in the ER, and he came in. He was very mad at me, and I was just seizure after seizure. I was having clusters, and he came in. He says, "What are you doing here, and what do you think you're doing?" And I was just grabbing the rails of the bed, and I had bruises all over. And I couldn't get out of it. And he said, "Stop it," but they never came back in to give me anything. I told him my doctor to call. I had a letter. I went to another hospital at a different time, and they called the security guard on me. And after a few minutes, I guess he couldn't take it or something was going on. And then he just left and they just left me, once I calmed down a little bit, but they wouldn't give me any medication. Eventually, I'd give them the information. They would keep the letter. I kept asking if they called. Wouldn't call her. I had a medical bracelet and necklace. They took it off of me and didn't call the number. And, to find out what medications I was on. There was one that nurses was laughing at me. Doctor was laughing at me.
But I have to mention this because Cheryl has frontal lobe seizures, so they are they're very unusual in presentation. And there is a lot of stigma surrounding epilepsy and seizures, and I think Cheryl has suffered from that. Some seizures were not recognized as being epileptic, and so she suffered from that, and they were not treated as being epileptic. Well, it was proven. I mean, we had followed her, demonstrated with monitoring that she had epileptic frontal lobe seizures. And I had even to give her a note that she will carry with her that she does have epilepsy. She's, at that time, I think she already had the first brain surgery 4 years ago.
Yeah.
And that she's on these medications and to contact me just because. And I think what happens with patients who have very difficult to control seizures and certain types of seizures, it really it puts a lot of, even on the medical field, physicians and nurses uncomfortable, and sometimes they feel helpless. They don't know what to do.
Yeah.
And I think this was a little bit what Cheryl had to deal with and struggled with.
Yeah. I'm very blessed. I called a previous neurologist that worked here, Dr. Sabula, and I talked to her, and she said, I'll get you in. I'll talk to Dr. Benslem. So I was very
That's
fortunate
picked up
to get back to UK because it was my first home, and I'm still home. This is home to me no matter how far we live. I'm just gung-ho UK. And that's not to advertise. I get so much great treatment. And, if you guys told me to jump and bark like a dog, I would.
We won't ask you to do that.
I wanted to give Dr. Karp a chance to. Michael Karp is our Executive Vice President for Health Affairs, and I know this is warming his heart to hear this story this morning. He came here some 11 and a half years ago, and I think his vision is being carried out. Dr. Karp.
Yeah, this is a wonderful example of what we've tried to do at UK. We committed a little over 11 years ago that on campus here we would develop an advanced research-intensive referral institution that would be able to take care of Kentuckians no matter how complex their problems, no matter how unusual their problems, so they would be able to stay in Kentucky and not worry about whether their insurance will allow them to get health care at the Mayo Clinic or the Cleveland Clinic or a place like that. To be able to accomplish that, you need to really invest in teams and the equipment that makes teams be able to function. So taking care of complex epilepsy, or taking care of epilepsy, it's not about a single doctor, it's about a team. It's having an epileptologist, we have a team of epileptologists that Dr. Benslem heads up, having a neurosurgeon involved, having psychologists and social workers, and a whole slew of people that take care of folks. And it's about having the facilities, the monitoring facilities, and then bringing new technology like the Neuropace system. So this really is a demonstration of what we committed to, and that we're living up to our commitments and our goals. And as the saying goes, that's why we're here.
Yes.
Very good. I think at this time would be appropriate if we open it up for questions from the news media. If you have a question, please raise your hand and we'll recognize you and give the opportunity. Any of our speakers this morning?
So does this device, you said the seizures are 50% of what they were. Will this device allow the graph to start going to 40%, 30%, 20%, or once you put the device in, that's where it's going to be?
So I will take this question. So the device actually, we program it over time. It's a process, and we may sometimes even see results several months later, or even a year or two later. In addition to delivering therapy on demand, it has also capability from the results that we're seeing from the studies of neuromodulation. That means that over time we still continue to see results, even if we stop changing the settings, the parameters. I'm sorry. And when Cheryl, this is her perception of seizure decrease. What the device does for us, it will detect the seizure, so we recognizes patterns, detects them, so we can have a count from that. And then, depending on what information we get, we change several settings. We kind of fine-tune the device. And so far, we've been seeing, Cheryl, we did the first programming a month ago. We're going to do another programming today. And just the implant was placed 2 months ago, so a couple of months ago. So pretty much every month we'll continue to see Cheryl, and we will fine-tune the settings until we get the best response. But again, even after we stop from the data from the research, the trial data, it appears that even when the settings stop to be adjusted, there still continues to be some benefit from the device.
So it's hard to predict to what degree your seizures will be in the future?
It's hard to predict with any, and we always hope that it will. I think it's very reassuring to see a response so far, because this is very recent. I mean, this happened, the first programming happened a month ago. Of course, with Cheryl having very frequent daily seizures, we'll be able, I think, to have a good idea in the next few months of the impact. But it's very reassuring to see that herself feels that she's having less seizures and she's having more energy and is capable to do more things and willing to do more things now.
Timeline-wise, are we talking several days now between, or weeks between seizures? It just varies.
Oh, for Cheryl?
It varies.
It varies, but she has daily seizures, so she can have several seizures a day, and it's every day pretty much.
So it's still daily.
Oh, it's still daily, yeah. But she can have 40, 50 seizures a day, so or more.
Yeah.
So sometimes they're too numerous to count, actually. But so she's a case who has very severe epilepsy, a case of severe epilepsy. So some of them can be more what we call focal. The presentation is milder, and some of them are more elaborate when she has what we are known as grand mal seizures or generalized tonic-clonic seizures, where the whole body convulses.
Well, what's really nice about this device, and getting to both of your questions, is that we're capturing the data from the seizures when they happen, and we can learn from that, and we can go back in, and Dr. Ben-Salmon can program the device to get better control. So this really is the tip of the iceberg of this new technology. Whereas before, you might get a report that a seizure happened, but you really don't know what things look like inside the brain, and this allows us to do that.
It actually opens a whole new door. I mean, we're not only we'll be able to offer a new therapy to very difficult to control patients who have epilepsy with medications, but also it will basically, it's giving us a better understanding, and hopefully it will give us a better understanding of brain functioning because we're collecting all this data that we will analyze.
Other questions? Yes, Stu?
Realizing that Cheryl's a kind of pioneer patient, really, treatment, but over the next, say, 5 years, any idea of how many candidates might be suitable for this procedure?
In Kentucky, or we have few patients lined up for the next few months already for surgery or candidates, and these are patients. So this device, this new technology, is not for. It's for patients who are very difficult to control with medications. So they have to fail at least 2 anti-epileptic drugs or more. And most of the patients that we see have failed several of them, if not all of the anti-epileptic drugs or anti-seizure medicines available on the market. But also for patients who cannot have traditional epilepsy surgery because either they have more than one source for their seizures, so we can't just go and chop brain here and there and remove it, or they have a source, the source of their seizures, it's in an area that is not negotiable, that we can't remove because there is function, and there is no backup for that function, like language, motor function, or vision. So we can't remove these areas with traditional surgery, resective surgery.
How many places in the country do this procedure?
So far we have 27, there are 27 centers offering this procedure. Of course, in Kentucky, we're the first one. And there is David Green here from clinical engineering with Neuropace, who's been, but this device has been implanted. I think the first patient was like 10 years about.
And the feasibility trial, we started that in 2004.
Yeah.
It was a 2-year study that led into a double-blinded randomized control trial that began in 2007.
So by the time the FDA approved the device, if I'm correct, correct me, David, if this is incorrect, there were 256 patients who were implanted. And so after the approval, there are, more centers now opening and offering this therapy. But we're 1 in 27 in the nation.
Yeah. It's just not me, feeling I'm sorry, I lose words, the positivity, about the 50%. You can ask my family, when my boys and my mother, about how much better, I don't have to grab onto the walls, afraid to, or shaking like I'm going to go into a seizure, and they have to watch me, and they're so tickled about it, like I am. I mean, they really there, and they've been through a lot. My husband's been through a lot and stuck with me through this, and you can ask them.
It's been a long journey, yeah. It's been a long journey for Cheryl.
Yeah, I know it's not going to be overnight, but I'm just so proud of them about how they, have really stuck by me and not panicked. They just stuck right in with Mom. And I just want to thank you.
Of course,
boys.
they have to stuck with Mom.
Anyone else?
If I could ask, from a surgical standpoint, how frequently will the pulse generator, the battery on this device, need to be changed, or is that dependent on how significant her settings are?
Yeah, that will depend on the settings. That takes about 5 years, but it depends on the settings and how often and how high the stimulation is delivered.
Well, I think that this is a good time to close the formal proceedings. We invite the media for individual interviews with Dr. Van Horn, Dr. Ben Slamoan. I'm sure Cheryl would be willing to entertain an interview or two, Dr. Karp, and anyone else that you want to talk to. We thank you all for coming, and Cheryl, God bless you and good luck.
Thank you very much.
Thank you.
Thank you. I'm good.
Thank you.
It's so much.
Thank you so much.